video will cover discussion and demonstration to the team approach of client therapy. They are orthotics and bed positioning. Following the video, you'll have a chance to practice applying orthotics and bed positioning during a lab session. The video can be stopped at the end of each section for questions or clarification. The definition of orthotics are mechanical devices used to hold a limb or joint in a certain position. Let's take a look at some examples. This is a hand splint made out of thermoplastics. This is used to keep the wrist and hand in a resting or functional position. This is an anti-spasticity or finger spreader splint. This splint is based off the theory that keeping the fingers in a spread position will reduce tone throughout that extremity. This is a hand cylinder made out of thermoplastic or high-density foam. The purpose of this orthotic is to keep the hand in an open position. Ultraflexes and Dynasplints are used usually for the elbow or knee joints. The larger cuff fits around the upper arm, the smaller cuff around the forearm, taking care that the orthotic joint fits securely with the client's joint. There's a lock mechanism to assist with application and then disengaged to apply a stretch to the joint. The 3-point leg or elbow brace is similar to the Ultraflex in that it has an upper and lower cuff with knee strap to fit securely over the joint. Prafos are boot-type orthotics usually worn in bed to prevent heel cord shortening or tendon shortening. Why do clients wear orthotics? To prevent skin breakdown. Skin against skin promotes breakdown. To prevent contractures or tendon shortening, maintaining or gaining range of motion. Ease of care for clients, and to retrain the nervous system. Therapists use the words muscle tone, spasticity, and spastic tone. But what do these really mean? In order to understand, we must first learn about the human body and how it functions. Your nervous system can be divided into 3 basic areas: the brain, spinal cord, and peripheral nerves. The job of the brain is to be the control center or computer for the body. The spinal cord is the connection between the brain and peripheral nerves. The peripheral nerves are the nerves coming from your muscles and skin, giving information to your brain about your senses, as well as the nerves that go to your muscles to help tell you how to move. In order for your body to move, there are muscles on each side of your joint. Let's take your elbow, for example. Basically speaking, your biceps bend your elbow into what we call flexion, and your triceps straighten your elbow into extension. Therefore, your biceps are your flexors and your triceps your extensors. Some individuals who have a brain injury or other type of neurological impairment experience symptoms such as muscle tone or spasticity. This can be either flexor or extensor tone. To use your elbow again as an example, there's an overfiring in the nervous system to one side of the body, which creates an imbalance between the flexors and extensors. This feels like a stiffness when you're trying to straighten or bend the person's arm. One of the ways to help this is through the use of orthotics. Orthotics are based on the principle that if you hold a muscle in a prolonged stretch, you will retrain or quiet the nervous system. This in turn prevents the formation of contractures and allows us to either maintain or gain range of motion. Here's a demonstration on how to apply an elbow Ultraflex orthotic. First, talk to the client.
Feel good?
Yep. Prior to putting orthotics on, make sure the Ultraflex is in a locked position. It's important to do a short course of range of motion to the affected joints. Support the shoulder joint both posteriorly and anteriorly, or front and back. This is important to prevent dislocation. Use a firm, steady, but gentle pressure. And pay attention to the client's facial expressions for noted grimacing. When applying the Ultraflex, make sure that the orthotic joint matches up with the client's joint. Place the limb into the orthotic and fasten the straps. Make necessary adjustments and retighten straps as needed. After all adjustments are made, unlock the orthotic. For a final check, straps are secure, orthotic joint matches with client joint, no pinching is noted, and clothing is not wrinkled or bulky underneath, possibly causing pressure marks. When applying a hand cylinder or splint, first explain the procedure to the client.
Do some range of motion on your arm, okay?
Okay.
Flex the wrist or bend it downward. Bring the thumb out to the side, not back, and gently bring the fingers out from the palm, taking care not to touch the palm, which triggers a grasp reflex.
Feel okay. Feel okay.
Apply the hand cylinder and fasten the straps over the base of the fingers.
Feel okay. Feel okay.
When applying the Prefo or ankle-foot orthoses, bend the knee and take care to place the heel securely into the orthotic. Fasten the straps. To straighten the leg, use one hand above the kneecap and the other to extend the toes to assist with straightening the leg. Therapists establish a wearing schedule. This schedule outlines what orthotics should be worn while the client is in the wheelchair and in bed on their left or right side. Orthotic schedules are posted in the client's room with the therapist's signatures. Now I would like you to consider some things to watch for. Double check to make sure you have the correct splint on the correct extremity. Orthotics are costly. Please take good care of them. A hand splint begins in the range of $130, an Ultraflex around $300, and a brace around $600. Please report worn or dirty areas on orthotic devices to the appropriate therapists. And upon removal of the orthotic, check for reddened areas lasting more than 20 minutes. Remove the orthotic and bring to the therapist. Common areas for pressure marks include bony prominences such as knees, ankles, and wrists. This concludes the orthotics section of this video. Remember, bed positioning and orthotics are all extensions of therapy. Purposes of bed positioning are to normalize tone, prevent pressure sores, and prevent aspiration. Before performing bed positioning, make sure to position yourself so you can use proper body mechanics.
Morning, Gina.
Pull the bed out from the wall if necessary and bring the bed rail down. Position the height of the bed to your hip level and flat. Turn off any feeding equipment. Follow the following steps to position the client into side lying. First, tell the client what you're going to do.
I move you up in bed, Gina.
Make sure the client is at the head of the bed. This can be done by using the draw sheet. Put a pillow above the head and count to 3.
On my 3. 1, 2, 3.
Take care to use proper body mechanics. If the client is to be positioned on her right side, bring her all the way to the left side of the bed. Place hands under the shoulder blade and hip
1, 2, 3.
and move one body segment at a time.
1, 2, 3. And 1, 2, 3.
To turn the client on their side, put your hand behind the
Hold
shoulder
on to your
blade
side, okay.
and hip, keeping the spine in alignment.
Okay.
Position the bed wedge securely behind the client to support the trunk, and bring the bed rail up to secure. Make sure the client is not resting directly on their shoulder. Rather, they should be resting on their shoulder blade. Place pillows under the client's head and between the knees and arm.
This is pillow between your knees.
And the chair up.
Raise the head and foot of the bed.
Are you comfortable?
Make sure side rails are up and turn on feeding equipment. This is side lying positioning. If we look at the bed wedge, there is a specific shape. Looking at the bed wedge from this edge goes along the bed rail and this edge toward the mattress. The width is small on top and widest along the mattress. This concludes the bed positioning section. We are here today to explain and teach to you the importance of passive range of motion to our clients. Passive range of motion is described as movement of a joint within an unrestricted area of motion that is produced by a gentle external force. This external force comes from you, the caregiver. By unrestricted, it is meant that if obstructions are felt, they are never to be pushed through. The motion would stop at the point where the obstruction is felt. Passive range of motion is important for the health and well-being of the client, and is especially important for the health and nutrition of the client's joints. Joints do not have a typical blood supply like our muscles and organs. Joints receive all of their nutrition through range of motion and through compressive distractive forces, such as when you are walking. Clients who no longer can move or bear weight through their joints independently are at a disadvantage to provide nutrition to their joints, and thus we must provide it for them. The following is a list of benefits from passive range of motion. Prevention of contractures or limitation in a joint's movement from occurring. If contractures occur, it usually makes your job as a caregiver more difficult. For example, during showering or dressing. Maintain adequate joint nutrition as noted above. Enhance circulation, thus helping to minimize the risk of blood clots. Decrease and sometimes prevent pain associated with immobility. It is important to realize that some range of motion can be painful for a client. Thus, you must always watch their face and body for pain responses, such as a wince during the range of motion session. Assists to enhance the client's awareness of movement and often will speed up the rehabilitation process by progressing them from passive to active range of motion more quickly. In this video, you will learn the proper technique to perform passive range of motion exercises. Before you start, take care to always use universal precautions. Remember to turn off all feeding equipment and position the client on his or her back using proper body mechanics. For shoulder flexion, support the back of the wrist, hand, and elbow, along with the shoulder both anteriorly and posteriorly. Take the hand up and over the client's head while holding the arm in a straight position. Be sure that the client's thumb points in the upward direction. This motion is shoulder flexion. It's important to be aware of how fast you're moving a limb through its range of motion. High speeds are undesirable because with some clients, it actually makes the motion more difficult and can cause pain or injury to a joint. Keep yourself moving slow and smooth as demonstrated, using your body to initiate the motion, not your arms. With the same positioning, move the arm out and up to the side into shoulder abduction, with the thumb pointing in the upward direction. Bring the client's arm back to their side for shoulder adduction. For external rotation, support the elbow and shoulder and bring the hand toward a 90-degree angle. Bringing the hand down is then internal rotation. For elbow flexion, support the elbow above and below the joint and bend the forearm toward the shoulder. For elbow extension, bring the arm into a straightened position while providing a good amount of support to the shoulder. In forearm supination, rotate the palm upward or toward the ceiling by supporting the wrist and forearm. Rotating the palm downward would then be forearm pronation. For wrist flexion, bend the wrist in a downward motion, and then back up for wrist extension. Wrist movement in a side-to-side motion is wrist deviation. Once completed, while holding the thumb out of the way, slowly and gently straighten each finger at each joint, beginning at the base and moving toward the fingertips. This is hand opening with finger extension. While holding the fingers out of the way, move the thumb up and down and in and out, being cautious not to apply excessive force to the thumb area. This is thumb flexion, extension, and abduction. Begin with the client's leg in the extended position. Stand at the side of the client's leg and assume good body mechanics. Cradle the heel of the foot in one hand with the ball of the client's foot resting on your forearm. Place the other hand behind and above the knee joint. Bend the knee toward the shoulder on the same side. As the knee bends toward the shoulder, be sure to reposition your hand toward the client's thigh. This will allow for full range of motion to occur and produces knee and hip flexion and extension. Repeat 5 to 10 times. After the last repetition, maintain a 90-degree angle at the hip and slowly bring the heel of the foot toward the ceiling. Hold 20 to 30 seconds and repeat 2 to 3 times. This stretch is the straight leg raise stretch. Maintain the 90-degree angle at the knee and hip, and rotate the foot in and out to perform internal and external rotation of the hip. Straighten the leg and bring it out to the side as if making snow angels, into hip abduction and adduction. Next, continue to maintain the leg in a straight position and assume the previous hand hold with your hand around the heel and your forearm contacting the ball of their foot. Lean your body toward the client's head and apply an upward force on the client's foot. Hold 20 to 30 seconds and repeat 2 to 3 times. This completes ankle dorsiflexion stretch. Now draw circles with the toes to create ankle circumduction. Curl the toes up and down for toe flexion and extension. Next, bend both the client's knees and stabilize yourself by placing one knee on the bed. Cradle the client's legs and move the knees from side to side while stabilizing the upper body to create trunk rotation and flexion. This concludes the range of motion video. Transfers can be defined as moving a client from one surface to another. This can be done in many ways, depending on the client's status. It will be very important for you to be able to perform transfers safely and efficiently to protect both yourself and the client from injury. This video will cover general transfer information, proper body mechanics, one-person transfers, including the squat pivot transfer, the sliding board transfer, the standing pivot transfer, the two-person transfer, the LIGO lift transfer, and car transfer. Before beginning a transfer, always introduce yourself and explain to the client what is about to occur. Always use good body mechanics and universal precautions. Use shoes and bracing appropriately to assist with the ease of the transfer. Typically, it is more helpful to remove upper extremity bracing and apply lower extremity bracing and shoes during a transfer. Be aware of tubing present before the beginning of the transfer. This will prevent tubes from getting pulled or pinched. Also be sure that catheter tubes are attached to a leg strap before the transfer. Always be aware of sharp edges on the wheelchair and cut long nails and remove jewelry that may scrape a client. Be respectful of the client's modesty and treat them how you would want to be treated or how you think their loved ones would want them to be treated. Proper body mechanics are necessary to make the transfer safe for both you and the client. Use the 4 B's to remember them at all times. Base of support needs to be wide, meaning feet shoulder width apart or greater. Bending occurs at the hips. This is best performed by remembering to bend your knees and push your buttocks out. Back needs to be kept in a neutral position, meaning a small curve should be maintained in the lower back area. No bending occurs in the spine. Body-to-body contact must be maintained during transfers. The first part of a transfer includes wheelchair preparation. Use the acronym CLAPS to remember what is needed. Chair is positioned parallel or at a slight angle to the surface you are moving from. Lock brakes. Armrest on the transfer side is moved out of the way. Plates for the feet are removed or swung out of the way. Seat belt and other straps should be placed in an optimal position for refastening after the transfer is complete. The second step is client preparation. Explain to the client what will be occurring.
Good morning, Derek.
Hi, Dan.
I'm gonna get you up right up with therapy today, okay?
Apply any appropriate bracing or shoes. Cross the leg furthest from you over the other leg. Roll the client onto their side to face you. Bend their hips and knees to bring their feet off the edge of the bed. Place your hands at their shoulder and their hip to facilitate the client to a sitting position. Once sitting, the client needs to scoot forward. To assist this action, cradle one shoulder and lean them to the side. This unweights one hip, allowing you to move it forward. Repeat the same procedure on the opposite side. Continue until they are at the edge of the bed. Be sure to maintain client contact at all times. Once on the edge of the bed, the actual transfer will begin. Place your feet outside of the client's feet. Contact your knees around the client's knees, holding them in place to prevent them from buckling. Grasp the transfer belt around the client's waist. Remember the 4 B's. Base of support is wide, back is neutral, bent at the hips and not the spine, and body-to-body contact. Count to 3, and on 3, perform the following motion. Lean back and use your body weight and your knee-to-knee pivot point, not your arm strength, to lift the client's buttocks off the surface. Once the buttocks are clear, pivot so that you face the surface the client is transferring to. Notice as you pivot your feet, the client's feet will also pivot. Once the transfer is complete, you must position the client in the wheelchair. First, you must scoot them back in the wheelchair. Cradle the client to unweight one hip or use knee-to-knee contact to guide the unweighted hip back in the chair. Repeat side to side until the client is all the way back in the chair. To ensure the client is all the way back in the chair, lean their upper body forward and slide your flat hand between their buttocks and the chair back. If properly positioned, you should feel both surfaces with no gaps. Apply the seat belt and other positional straps. Replace the armrests and footrests.
Thanks.
Apply any necessary bracing. Take 2 steps back and observe the client in their wheelchair, looking for any asymmetries, especially in the hips, and be sure that the client looks comfortable. Sliding board transfers are very similar to squat pivot transfers. They work especially well for obese individuals, clients who are non-weight bearing in their legs, or clients just learning to participate with their transfers. Repeat the previous procedures for wheelchair and client preparation. Once the client is sitting at the edge of the bed, elevate the bed slightly higher than the wheelchair to allow gravity to assist you in the transfer. Position the sliding board by using the cradle technique to unweight the hip closest to the surface you are moving towards. Place one end of the sliding board under the buttock region and the other end on the surface you are moving to. Repeat the previous steps from the squat pivot transfer. However, as you pivot, slide their buttocks across the board instead of lifting their buttocks up.
Go way over 1, 2.
Position the client comfortably in the wheelchair as discussed before.
Standing pivot transfers work especially well with clients who can actively participate in the pushing part of the transfer. Repeat procedures for wheelchair preparation and client preparation as previously demonstrated. Once at the edge of the bed, assume the same body position as in the squat pivot transfer. When performing the stand pivot transfer, the only difference is that the client will be assisting to come to a standing position on the count of 3 by using their leg strength instead of maintaining a squat position. Once the client is standing, take small steps as you guide them to the wheelchair. Assist the client to sitting and position them comfortably in the wheelchair as discussed before.
Comfortable?
First, perform wheelchair preparation. Use the acronym CLAPS to recall the steps. Position the chair, lock the brakes, remove the armrest, remove the foot plate, place belts and straps in optimal positions for easy access after the transfer. We will now discuss and demonstrate proper positioning. Top person position. The top person sits the client up in bed. Place one leg on the bed edge and one leg in between the bed and the wheelchair. Position yourself behind the client and reach under their arms to grasp their forearms. Hold their forearms firmly to their chest and their body firmly to your body. Do not grab or lift client from the armpits. Bottom person position. The bottom person stands at the side of the client and assumes the 4B position with feet in a wide lunge stance to allow for forward and backward weight shifting. Scoop one arm under the thighs and one arm under the calves. Keep your body low to the ground. To perform the transfer, the top person counts to 3. On 3, both positions transfer their weight from one leg to the other and position the client on the edge of the bed. Use the strength in your legs to perform this lift, not your arms and back. The top person repositions his feet with one foot in between the bed and the wheelchair and one foot behind the wheelchair. Repeat the count and lift into the wheelchair.
2, 3.
Position the client as previously demonstrated. Place the sling under the client. Roll the client to one side and place the rolled sling under the client. Make sure the loops are facing the outside. Then, roll the client to the other side and unroll the sling. Make sure the center loop lines up with the spine. Tuck the leg portions of the sling around the client's hips and bring the long portion of the sling underneath each leg. Be sure to eliminate all slack and all wrinkles to avoid pressure areas. Maneuver the lift so it is over the client's chest, approximately 6 to 8 inches away from the body. Attach the sling to the hooks. Cross the right leg loop to the left hook and the left leg loop to the right hook. Raise the lift by using the handheld controls. Once clearance of the bed is achieved, position client's legs off the edge of the bed.
Let's get the legs off. Right back you up.
Turn the body of the client until it faces toward the display side of the lift. Maneuver the lift around the wheelchair by widening the lift legs using the lever just below the unit's display. Apply the lift brakes.
You want you down? Okay.
Slowly lower the lift as you guide the client back into the wheelchair. Remove the straps from the hooks and maneuver the lift out of the way.
How you doing?
Be sure the client is all the way back in the chair using the previous technique. Remove the sling straps from under the client's legs and position them on the client's sides, or remove the entire sling. Position the client in the chair as previously demonstrated. Open car door. Position wheelchair as close as possible to the car. Make sure to leave enough room for helper and client to stand and pivot. Lock brakes and remove footrests. Help client to the standing position. Have client pivot so the back of their legs are against the seat. Slowly lower person into sitting position. Lift each leg into the car. To return the client to the wheelchair, reverse the procedure.